It's an honor and a privilege to be here today, and I'd like to thank the organizing committee for this invitation. Just a minute to share my slides. Do you see my screen?
Yes, we do, Dr. Saleh.
This is my disclosure. I'm going to speak today about the most recent HCC guidelines, which was published by Saudi Association for the Study of Liver Disease and Transplantation.
Dr. Saleh, would you please remove the presenter's view? Because we see both slides, this one and the next one.
Oh, sorry. Is it better now or the same?
Yeah, it's better. Can you put it in presentation mode, Dr. Saleh?
Okay, good. Let me stop sharing and sharing again. Is it better now?
Yes, Dr. Saleh.
Sorry for this. So the guidelines was published last October, and it was an update for the previous guidelines, which was published by my colleague, Dr. Ayman Abdo, and the liver team in Riyadh almost 10 years ago. We had our first meeting to coordinate these guidelines, and actually it was the last meeting we had personally before COVID-19. We thought to have a comprehensive guideline, so we gathered a group of hepatologists, medical oncologists, transplant surgeons, radiologists, and palliative care. And also we had two international experts in liver cancer, Dr. Alejandro Forner from Barcelona Group and Dr. Richard Finn from UCLA. And we had several meetings to develop these guidelines. Most of these people are experts in their field, and we thought many development was happened over the last year, especially in the systemic therapy. That's why actually Dr. Ashwaq was the person who took the most burden in this development of this guidelines. And I'd like to thank her for all her efforts in helping developing the systemic therapy and updating the previous guidelines. As you know, about 2/3 of liver cancer globally is in Far East Asia, and the rest of the globe had about 1/3 of the liver cancer. The GBD estimate the prevalence of liver cancer in Saudi Arabia is about 4.5 per 100,000. There is a recent study which was published last year about the epidemiology of liver cancer in Saudi Arabia, and it estimated that the highest prevalence was in Riyadh, followed by Najran and Tabuk. This is a study which we looked at the indications for liver transplantation in Saudi Arabia over the last 20 years at King Faisal Hospital. And this is an important slide to link the future prevalence of liver cancer in our country. We looked at the indication for liver transplant at King Faisal in 2011 until 2019, and also compare it to the 10 years earlier from 2000 until 2010. We found initially, as you can see in the slide, that hepatitis C was the highest or the most common indication for liver transplant in the kingdom. However, in 2014, with the availability of direct-acting antiviral therapy and excellent response of hepatitis C to treatment, the hepatitis C is not becoming an indication for liver transplant. However, this has been replaced by fatty liver disease, which became the #1 indication for liver transplant in Saudi Arabia. And why this is linked to HCC, which I'm going to speak in the next few slides. Many patients with fatty liver disease, there is a certain percentage of them, they can develop liver cancer without cirrhosis. And this will make it a challenge in terms of surveillance for those patients. And also we have to be ready as a country for a future increase in the liver number, the liver cancer patients, in terms of building infrastructures, increasing manpower in oncology, establishing clinical trials in chemotherapy, and having access to the many drugs in chemotherapy. As you can see in our study, we found the most indication for liver transplant is 30% is almost NASH. And also we found 10 years ago, the highest, the number of patients who transplanted for liver cancer was 20%. However, over the last few years, this number increased from 20% to 30% as an indication for liver transplant from liver cancer. Globally, as you can see, the highest prevalence for fatty liver disease is in the Middle East, which is about 31.8%, followed by South Africa, 30%, and the rest of the world is about 25%. What is more alarming is the prevalence of fatty liver disease in patients with diabetes. As you can see, almost more than 50% of patients who you see in diabetes clinic have evidence of fatty liver disease. And what is actually becoming more critical in healthcare is the high prevalence of fatty liver disease in children, with about 15% in some countries of children, they have fatty liver disease. And this will have an impact in the future for having more patients who might develop liver cancer, unless we control the risk factors for fatty liver disease, which are mainly obesity and metabolic syndrome. This slide goes over the cascades. It's what happened for people with fatty liver disease. As you can see, initially, most people will have simple steatosis. Some of those patients, about 7 to 30% over 10 years, will develop non-alcoholic steatohepatitis, which is the more advanced form of fatty liver disease. Of course, certain patients will continue to develop fibrosis until they reach cirrhosis. And we estimated about 2.3% per year of patients who have cirrhosis secondary to NASH will develop liver cancer. However, what is alarming and make it challenging for all hepatologists is patients with NASH who can directly develop liver cancer or non-cirrhotic HCC, which is estimated about 0.6% per year, which makes it also difficult how to do screening or surveillance for liver cancer in those patients. Of course, as you know, the most common cause of death in patients with fatty liver disease early is not liver disease related, it's actually cardiovascular complications because of the high prevalence of metabolic syndrome in those patients. This is a study from the VA system in the US, where they looked at about 1,500 patients with HCC, and they looked at patients who might develop liver cancer without cirrhosis. Previously, we understand that the only patient who can develop liver cancer without cirrhosis are patients with hepatitis B. However, they identified about 13% of patients who develop HCC without cirrhosis. And as you can see here, the majority of those patients actually NAFLD, and about 34.6% of those patients who develop liver cancer NAFLD, they don't have cirrhosis. In our current guidelines, we agree with the AASLD and the European guidelines for the importance of surveillance based on many studies that revealed ultrasound every 6 months and alpha-fetoprotein will improve survival in patients with liver disease. The indication for surveillance in our guidelines are consistent with the international guidelines, in particular, a patient with hepatitis B and having a high risk of HCC based on either family history or age. Also, patient with child A and B cirrhotics. Child C cirrhotic, we did not recommend in our guidelines to have a routine surveillance unless they are in the liver transplantation waiting. However, as we all know, despite the importance of surveillance, it's not practically used in many patients. This is a study by Dr. Singhal and his group at UT Southwestern when they look at surveillance in their healthcare system. And as you can see, it's about only 25% of patients with cirrhosis, they are undergoing routine surveillance. They identify the barrier for surveillance, either patient-related or physician-related, in particular, timing of physicians, and also some patients who live far away from having an imaging available to have an ultrasound surveillance. What about those patients who go to ultrasound and alpha-fetoprotein every 6 months? As we know, ultrasound is not an excellent modality for surveillance. With some studies, they found ultrasound alone can detect only less than half of patients with early liver cancer. If you add alpha-fetoprotein, you can get about 15 or 20% extra sensitivities. And in conclusion from these studies, which looked at the predictors of surveillance failure, or basically patients who have failed to detect HCC early with ultrasound. And as you can see, the more people, the more obese, the more likely the ultrasound will not detect early liver cancer, and also patients with non-alcoholic fatty liver disease, and also patients with child C cirrhosis based on the irregularity of the liver service, which make it difficult for some radiologists to identify early liver lesions. And of course, some patients, they have extensive ascites. Now, if we say that ultrasound is not very sensitive for screening, especially in high-risk patients, maybe probably MRI would be more sensitive for those patients. However, because of the cost issues and unavailability, in our current guidelines, we could not recommend MRI as a surveillance modality. However, there are certain risk score systems which you can use when you see your patients. And if you have a patient with a higher risk of probability of developing a liver cancer, this patient, as case-by-case basis, might have a benefit from MRI maybe once a year at least for screening for liver cancer. This is a study came from Denmark. They looked at patients with PNPLA3 mutations, and they tried to come with the genetic scoring system. And they found based on their genetic scoring system, the higher the genetic score, the more likely the patient will develop liver cancer. Of course, it's difficult to do genetic testing for a majority of patients. This is a nice study from Dr. Kannan in Houston, Texas, when she looked at the presence of metabolic traits in patients with cirrhosis or liver disease, and she correlated the number of metabolic conditions in those patients and the risk of development of either cirrhosis or liver cancer. And she looked at 4 factors: obesity, diabetes, hypertension, and dyslipidemia. And as you can see, the more risk factors you have, the more probability your patient will develop a liver cancer. And based on her analysis, that diabetes is the strongest risk factor for development of HCC. So for example, if you see a 55-year-old patient in your clinic with fatty liver disease, who have diabetes, hypertension, or obese, probably for cirrhotic patients, it's worth to do an MRI maybe once a year for screening for liver cancer. And in between, you can continue to do the ultrasound and alpha-fetoprotein. Talking about how prevalent is liver cancer and how challenging are majority of those patients present late. it's always interesting to talk about prevention. And when we talk about prevention, we can speak about modifiable risk factor, for example, patients with hepatitis B or hepatitis C who best receive antiviral therapy. Lifestyle modifications are also important, and controlling other metabolic risk factors such as diabetes, obesity, and hypertension. There are also important rules for diet and some drug therapy in prevention of liver cancer, which I will speak in the next few slides. Hopefully in the future we'll have a treatment who can reverse fibrosis in patients with cirrhosis or advanced liver disease. When I see patients in the clinic, I start to counsel the patients, especially patients with fatty liver disease, about healthy diet, avoiding consumption of large amount of red meat, avoiding high salt food, and also encourage patients for physical exercise. And then when I talk to them about how beneficial is drinking coffee and liver cancer, patients start to feel happy, and he said, well, probably this is the most important thing I can do to prevent liver cancer. Coffee has been studied in many studies. For example, this is a meta-analysis looking at 12 prospective studies for about 3,400 patients with liver cancer. And as you can see, just regular coffee consumption will reduce the risk of liver cancer by about 34%. And there are other also studies looking at least 1 or 2 cups of coffee a day will reduce the risk of liver cancer by 30 to 40%. This has been more with caffeinated coffee. However, there are also some evidence that decaffeinated coffee have also a similar effect. We don't understand exactly the mechanism why coffee can reduce liver cancer. However, there are several theories based on caffeine as an antioxidant. It might increase the metabolism of carcinogens, and also it might inhibit virus activity in people with hepatitis B and help better control diabetes. What about diet and HCC? This is a nice meta-analysis from China when they looked at patients, more than 4,000 patients with HCC, and they found there is nice reduction of the risk of liver cancer for patients who consume large amounts of vegetables. However, when they did the same analysis for patients with fruit, they could not find consumption of fruit as protective from liver cancer. What about Mediterranean diet? This is also a nice study from Italy when they looked at a large number of patients in Italy and Greece, and they scored their compliance with Mediterranean diet from 0 to 9 based on the Mediterranean diet score, or MDS. And this score is basically asking the patient how many times a week they eat fish, vegetables, dairy products, olive oil, and nuts. And the more they consume what they called in their survey healthy Mediterranean diet, the more score they got. And they found people with higher consumption of or compliance with the Mediterranean diet, there is almost 50% reduction in the risk of liver cancer. This is a nice paper was published just a few months ago, looking at the general association between diet and HCC. I will not go to the details of their findings. However, in general, majority of the healthy diet are in the green, which can help reduce the liver cancer, in particular vitamin E, magnesium, beta carotene. If you look on the right side, food which might increase the liver cancer risk are processed red meat and sweetened beverages, and also high sodium diet. What about physical activity? Risk of liver cancer. This is also another study looking at the EPIC cohort of the European study group. When they look at large number of people and they correlate the incidence of liver cancer with a follow-up for almost 15 years. And as you can see here, people in the black line who are inactive have a higher risk of development of liver cancer compared to people in the green and the brown, which are more physically active. This is another important recommendations for patients to increase their physical activities, regardless if they have non-alcoholic fatty liver disease or other etiology of liver disease. What about statin? This is also a study came from Dr. Singh at the Mayo Clinic when they did a meta-analysis for a large number of studies, and they found patients who use statin are more likely to be protected from liver cancer compared to patients who didn't use the statin. However, we have to interpret these data with precautions. As we know in clinical practice, that patients with advanced liver disease or cirrhotics, those are the patients are having a higher risk of liver cancer, and in the same time are less likely to receive statin as a treatment for their dyslipidemia. So maybe some of these studies have a selection bias. This also has been confirmed with other studies when they looked at what are the types of statin which may be protected from liver cancer. And this study also from Mayo Clinic, they looked at lipophilic statins such as atorvastatin or simvastatin compared to hydrophilic statin such as rosuvastatin or Crestor and pravastatin. And as you can see, the protection of liver cancer was mainly evident in people who use lipophilic statins such as atorvastatin and simvastatin. However, the protection from liver cancer was not found in people who are taking rosuvastatin or pravastatin. What about bariatric surgery? As we know, bariatric surgery is becoming a common way of weight loss in patients who failed lifestyle modification and medical treatment for weight loss. This is a meta-analysis from Dr. Romay in New York, who looked at 100,000 of patients who underwent for bariatric surgery, including gastric band, sleeve surgery, and also bypass surgery for weight loss. And as you can see, based on the study, patients who underwent bariatric surgery, they have less risk of liver cancer compared to patients with liver disease who did not undergo bariatric surgery. This is a nice paper, was published in New England Journal of Medicine this year about the role of aspirin and liver cancer and liver-related mortality. And as you can see here in this study, they looked at people who don't use aspirin. They have a cumulative incidence of liver cancer about 8% over 10 years. However, this incidence was almost cut by half, about 4% for people who are using aspirin. When they also looked at liver-related mortality, they also found people who use aspirin are having a better survival compared to people who are not using aspirin. What's also interesting from this study, they found no difference in the risk of GI bleed between aspirin users and patients who don't use aspirin. The next thing in our new guidelines, we updated the Barcelona staging and treatment system for liver cancer. As you can see, the BCLS staging and treatment system, which mainly used liver burden, liver function, and also patient functional status, has been used for more than 10 years for the treatment of liver cancer. However, with the new guidelines, we updated the staging system with a few differences, which I can emphasize it here. We looked at number one, we changed or the definition of preserved liver function has been changed in the previous BCLS staging system. They were only emphasizing the child score. However, with the current system, we also emphasize the presence or absence of ascites. Also, the second change in the new guidelines is ablation become a first-line treatment for patients with small HCC and preserved liver function. In the past, resection was number one modalities. Also, in this new guidelines, we have more methodological way to assess patients for risk of surgery. The fourth change was systemic therapy. The previous guidelines were only talking about sorafenib. However, there was, as you noticed from Dr. Ibrahim and other colleagues' lecture today, there is a huge development in the liver systemic therapy for liver cancer. And the last change in the current guidelines is non-transplantable HCC in the terminal stage. So the first change, as I mentioned, the preserved liver function. We found from number of studies that the presence of ascites has an important predictor for morbidity and mortality for any treatment for liver cancer, regardless if it's ablation, surgical resection, or interventional radiology. So preserved liver function now changed to patient must have child PUA and don't have any evidence of ascites. Any patient with ascites considered to be not preserved liver function. The second change, as I mentioned, is we changed the way how we can assess patients for liver resection. As you can see, if you have a patient with small HCC and you want to assess if this is a patient best treated with ablation, resection, or transplantation, you assess the presence or absence of portal hypertension. For patients with no evidence of portal hypertension, then you look at the extension of hepatectomy. If it's minor hepatectomy or less than 3 segments, you assess the MELD score. If the MELD score is less than 9, those are the best patients to proceed with resection because they have 5% risk of decompensation from surgery and also have a very low risk of mortality from the surgery, which is about 0.5%. However, if the patient has evidence of portal hypertension and the extension of the hepatectomy, either major or minor, those are the patients that have intermediate risk or high risk from liver resection surgery, which you probably should avoid surgery in those patients because of the high mortality and high morbidity from the surgery.
Dr. Saleh?
Yes.
2 minutes to conclude, please.
So this is also help when we see patients in the clinic. I look at the presence of portal hypertension, extensive hepatectomy. If it's in the green area, this is the patient who I would refer to the surgeon. If it's in the yellow area, as unfortunately majority of the patient, those are the patients who have to discuss the pros and cons of surgery. And if they are in the red zone, those are the patients who have an absolute contraindication for surgery. As I discussed, ablation becoming an excellent method for treatment for early HCC, especially patients with less than 3 centimeters. As you can see, this study looked at comparing almost 4,000 patients who underwent resection compared to 4,000 patients who underwent RFA. And as you can see, just looking at the survival, almost the survival is similar between resection and RFA, although maybe recurrence a little bit higher in the RFA group. But generally, when they looked at adjusted life expectancy, quality of life, and cost analysis, RFA become more cost effective for those patients. That make ablation is attractive treatment for in general patients. Now, the last thing about systemic therapy, we have an excellent lectures today by many of our distinguished speakers about systemic therapy for liver cancer. And in our current guidelines, we agreed that for patients with preserved liver function, atezolizumab plus Beva will be the first line therapy, and sorafenib or nivatinib will be an alternative treatment. This was based on the best available evidence when we developed the guidelines. If you disagree with this, you can't blame Dr. Ashjan because she's the one who recommended this in our guidelines. This is my last slide. My last slide maybe is important for people who use immunotherapy frequently for liver cancer. In about 5 to 10% of patients in immunotherapy, they can develop hepatitis or toxicity, and how to manage those patients, usually based on the degree of liver dysfunction. For patients who develop ALT and AST elevation less than 3 times upper limit of normal, those are the patients probably you can continue treatment with frequent monitoring. I would recommend liver function test on a weekly basis. For those patients who start to develop more than 5 times upper limit of normal, those are the patients probably need to hold treatment and consider steroid therapy. Once they reach 20 times upper limit of normal, those are the patients who probably permanent stop of immunotherapy, starting IV steroid therapy, considering a liver biopsy. I'd like to thank you everyone for again for the opportunity to speak to you today, and I'll be happy to answer any questions.